further ado, James, let me introduce you. First of all, thanks everyone for coming. I know this program's really early, but we do have about 3 years of funding, so we're really excited to keep it moving. And every month, we're hoping to get speakers better and better. It's going to be hard to beat James, but hopefully I can get him to do another talk soon. So James is a friend of mine and a friend of yours. He's a Rudy doc, he's an emerge doc, and he also does EPOS, so he helps transport patients all around the province on a regular basis. He's also quite a name in IT and Wikipedia and writing articles for the whole world to read about emergency medicine. So James, it's really a pleasure to know you and work with you, and thanks a lot for offering your skills and expertise to the group here today.
Perfect. Wonderful. Thank you. So without further ado, let me see if I can get this working. So first what we're going to do is we're going to go over agitation in the emerge. So our objectives here is to develop a stepwise process to manage agitation in the ER, to appropriately evaluate the agitated patient, and then to describe how to prepare an agitated patient for transport from where you are to where the patient ultimately needs to be, which is often with further psychiatric assessment. So I'm going to quickly present some cases here just for, that I want you guys to think about as we go through this talk. 32-year-old male brought in by RCMP, was found running around outside with no clothes on. Paramedics report unable to assess. Patient is aggressively struggling with a police officer on each limb and is covered with sweat. So I want you to think about this case as we go through these slides. So agitation is a presentation, it's not a diagnosis. And underneath agitation may lurk a psychiatric diagnosis, may lurk a medical diagnosis, may lurk trauma, may lurk a toxicological issue. And the key is that all these patients need to be calmed before you can appropriately work them up and keep them safe. So the first step in addressing agitation is to categorize it. Agitation varies from mild, and this is those folks who are cooperative, who can be reassured, who can be calmed down, to moderate, who, these folks are disruptive, but they're not in any danger to themselves, they're not in any danger to others, and they can be calmed when asked. And then you have the severely agitated patient. And these are your excited delirium, and these folks are not only a danger to themselves, but they're also a danger to the staff and to all those around them. And this is really a life-threatening event that needs to be dealt with as the emergency that it is. With respect to recognizing agitation, here we have the classic signs of agitation in a dog that all of us recognize. You see the dog curl their lips, you see, them bar their teeth, you see stiff-legged, raised tail, raised hair on their back, and, you can see the wrinkling of their forehead. And in humans, we have very similar signs of agitation. So, when someone is agitated, we'll see them being restless, we'll see them raising their voice, we'll see them speaking quickly, we'll see them fidgeting, unable to hold still. They'll often be, speaking loudly. If you look closely, they'll be standing there with their fists, their fists clenched. They won't look at you in the eyes. They'll be sitting there with their arms folded, and they won't obey commands. And all these are signs of agitation in humans, in line with the signs of agitation that we recognize in other animals. And these are very, very innate and are present across cultures. So our next step is looking at managing mild to moderate agitation. And for those who are mildly to moderately agitated, our first step is we want to try to address things with a non-medication based approach. And for those who are just slightly agitated, often you can bring them around by using supportive language, by trying to work together with them, by empathizing, getting across that, you realize that they have been through a lot of difficulty lately. And of course, they wouldn't be there if they wouldn't have gone through a great deal of difficulty. And, naming their emotion, validating their emotions, recognizing that their emotions may be appropriate for the situation they're in, and then make sure that the patient understands that you're there to help them. For those who are more moderately agitated, these who, people are starting to move into being at risk to themselves or others. And these are the folks who are often, brought in under the Mental Health Act. You're going to be committing them under the Mental Health Act. You still want to give them some options. But you don't want to give them entire control over what direction you're going into. So the language I often use is I'll say, it appears that you're upset. I want to give you something to help calm you down. Would you like a pill or would you like a shot? And they don't get the option to refuse both of them, but they do get some options with respect to their decisions. And then once you move into the more severe agitation, these are the cases where you want to call a code white, where you want to bring in an entire team to address this patient to make sure that you keep yourself and you keep your staff safe. And before going into these sorts of situations, you want to gather your team. You want to determine the roles of each person in advance. You want to prepare the medication before you confront the individual, and then you want to, make sure that you have a safety plan and an exit plan for how you're going to, get out of that situation if things were to go sideways. And then finally, you're going to be giving these, the individual medicines at this point in time that have the potential to result in respiratory compromise. So you want to make sure that you have an appropriate plan to support this person's airway after the medications are given. And then step 3, physical restraints. And chemical restraints. Physical restraints should only be used in combination with chemical restraints. Physical restraints are only appropriate for a short period of time and should be removed as soon as they're not needed, and that is generally 15 to 20 minutes depending on what sort of medications you're using to sedate your agitated patient. Concerned with prolonged use is that people in these physical restraints for a prolonged period of time can develop electrolyte abnormalities. They can develop significant amounts of muscle breakdown such that they go into rhabdomyolysis, and these electrolyte abnormalities can result in cardiac arrhythmias and death. With respect to applying physical restraints, this ideally involves 6 individuals, 1 on each limb, 1 supporting the head, and then the 6th individual there to give medications. Now, depending on your community, depending on where you're working, these individuals could be police. They could potentially be fire. EMS is another potential resource. Occasionally you can get nurses from other parts of the hospital come join you. Some places have security staff. One useful trick during physical restraints is that, an oxygen mask can not only provide oxygen, but it can prevent you from getting spit on, which is, of course, even more important in this time of COVID. With respect to the keys of putting someone in physical restraints, the key is to always use 4-point or 5-point restraints. So, have all 4 limbs restrained. You should never put a person in 2-point restraints. You want to use medical grade restraints. You want to restrain the person on their back rather than on their front, like they sometimes do in the movies. And then you want to have them restrained with 1 arm above their head and 1 arm below their waist. And this is something that, isn't necessarily intuitive, but is recommended. And then as soon as you do have the person restrained, you want to elevate the head of the bed to 30 degrees, just like you would with a stroke, to keep the person more comfortable. You want to have these restraints fixed right to the bed frame itself, not to the bed rails, as those rails are able to flop up and down. With respect to what not to do when putting someone in restraints, you don't want to restrain someone on their stomach, as that increases their risk of airway complications. We touched on the bed rails. We touched on the issues around 2-point restraints. And then one thing that might not necessarily be intuitive is you don't want to use a pillow under a person's head, as this can actually increase someone's risk of suffocation, as it will tilt their head forwards and it can potentially compress their airway. It's best just to lift the whole head of the bed to 30 degrees. Here is a picture of someone appropriately restrained. What you see is both arms, both legs attached to the frame of the bed, one arm up, one arm down, head of the bed to 30 degrees, and that's the 4-point restraint technique. And then once you have the person in restraints, if needed, and you then want to start considering calming. Well, you wanted to start considering calming mechanisms even before this, but this is, these medicines are basically key to allow you to rapidly stabilize and work the person up for life-threatening diagnoses. So, someone just has mild agitation, 1 or 2 milligrams of lorazepam is often sufficient. You can use antipsychotics rather than lorazepam. And then for people who have moderate levels of agitation, who are declining to take lorazepam, you'll often then look at using an IM option, either midazolam 2 to 5 milligrams IM or haloperidol 5 to 10 milligrams IM. And then with respect to someone who's presenting with severe agitation, so these are our folks with agitated delirium, the recommended first line treatment for these individuals is ketamine. Ketamine at an IM dose of 5 milligrams per kilo is very effective in getting the person in an accessible state rapidly. If someone's not quite so bad, haloperidol 10 milligrams and midazolam 10 milligrams. Sometimes I'll use 5 milligrams of haloperidol and 10 milligrams of midazolam, depending on how old and how much the person weighs, if they're not quite as severely agitated. Now, with respect to midazolam has the benefit of its onset is about 10 minutes. One of the concerns, however, is that those with alcohol on board may develop respiratory depression. So if you're giving midazolam, you will need to closely monitor this person. Now, there's a couple of pictures there on the right. And you will see that midazolam comes in 2 different doses. One dose is 1 milligram per mil. The other dose is 5 milligrams per mil. Now, if you're going to be giving midazolam IM, you need to make sure that you have the 5 milligram per mil solution, as you can only give, 3 mils maximum as an IM injection. So you won't be able to get that 10 milligram dose in. That would require 4 different IM shots. So, making sure that you have the right concentrations of these medications in your department is essential. Haloperidol has less respiratory depression than midazolam. It especially has less respiratory depression in those who already have alcohol on board. The one issue with haloperidol is it does take longer to work. So, often we'll combine midaz and haloperidol as, you'll get the benefits of both with hopefully less of the side effects. And then with respect to ketamine, we talked about 5 milligrams per kilo. Usually for RSI, we're using doses of 1.2 milligrams per kilo. For this indication, it is really a big dose. So 5 milligrams per kilo for a 70 kilogram male, that's 350 milligrams of ketamine. The benefit, however, is this will start working within 5 minutes. And, in those who are agitated, one of the concerns raised with ketamine is using it in people with high blood pressure, using it in people with high heart rates. But in those who are severely agitated, using IM ketamine actually lowers heart rate and it lowers blood pressure, as it calms people down very rapidly. One of the things you'll need to make sure is ketamine also comes in 2 concentrations. It comes in at 10 milligram per mil, and it comes in at 50 milligram per mil. So for this to be an option for you to give ketamine IM, you really need to make sure that you have the 100 milligram per 2 mil solution in your emergency department. And this is still 2 shots. You're still going to need like 6 mils of this stuff, and that is going to be 2 IM shots. With respect to some special populations, In older patients, you need to, worry more about respiratory depression, and you need to worry more about delirium with benzodiazepines. Older people are also very sensitive to antipsychotics, and the dose of haloperidol in this older population, you can, you see good effect often with doses as low as 0.5 milligrams of haloperidol. Low dose atypical antipsychotics can be used as well. Except, of course, in those who are in alcohol withdrawal. In those who are in alcohol withdrawal, you want to use benzodiazepines for all of them. And then some of the other keys with respect to the elderly, older people may get agitated, may get delirious due to pain. They may have issues due to anticholinergics, such as Benadryl or Gravol or many of the other medicines that we use. They may get agitated due to underlying diseases such as a heart attack, or they may simply get agitated due to separation from their family. So, now that you've had, you've calmed the person, you need to begin addressing immediately life-threatening concerns. So for the mild and moderately agitated folks, you have time to collect, details from police, collect details from family. You have time to do a head-to-toe exam after the patient has been fully undressed, and you have time to, order appropriate labs and imaging. For those who are more severely agitated, for those who are in an excited delirious state, there's a whole bunch of things you need to get to the first few minutes after the person has been, given ketamine. Once ketamine has been given, you want to place the person in a resuscitation room. You want to apply the person to appropriate monitors, including capnography, including oximetry. These are not the folks you want to give, a big shot of ketamine to and place in a secure room. Hospitals are getting secure rooms for various reasons in emergency departments. I do not find that they're the best places to manage acutely agitated people, at least initially. You need to have someone medically clear before it's safe for them to be placed in a secure room. Once you've given the person the dose of ketamine, you can then get in 1 or 2 large bore IVs. You can put in IOs if if IVs can't be gotten in, and then you want to start assessing them and treating key conditions that could be resulting in their state. So, for example, if someone's hypoxic, you want to place them on supplemental oxygen. One big key is checking for hyperthermia. And you need to do this quickly, as leaving someone at a temperature of 39 at a temperature of 40 for any length of time can cause severe temperature above 40 can result in severe and permanent neurological damage. So you want to obtain a rectal temperature, and then if that temperature is high, you want to initiate aggressive cooling measures. Of course, also with anybody who's agitated, you want to rapidly obtain a glucose and give D50W if the glucose is low. And then, most people who are severely agitated, they will have become volume depleted because of sweating, because of not drinking, not eating, because of the agitated state they're in. So, and they could also be potentially acidotic. So giving an initial 1 liter bolus of crystalloid, generally in the severely agitated, is perfectly reasonable. After that quick initial assessment, looking at those 4 key issues, hypoxia, hyperthermia, hypoglycemia, and hypovolemia, over the next few minutes, you want to deal with a few more issues. One is you need to send off labs, check the person's potassium, see if they're acidotic at all. You want to be checking the person's vital signs every 5 minutes for the first 30 minutes anyway, as you've given the person some ketamine. And then you want to begin, if you're working in a smaller center, you want to begin setting up transport with PTN. In the interior health area of things, these aren't the type of patients that can generally be moved by a BLS ambulance. You often need a higher level of care of patients. So in interior health, we generally use the heart team to move these patients. And many of them, will also need a CT of their head to fully medically clear them before psychiatry would be interested in getting involved. And then next you're going to want to start thinking a little bit deeper on what other conditions could have resulted in their current state. Could they have sepsis? Could they have neuroleptic malignant syndrome? Could they have, thyrotoxicosis? Could they have meningitis? And then rule out stuff like rhabdomyolysis and rule out issues such as traumatic injuries. With respect to someone who's agitated, there is a very extensive differential diagnosis that psychiatric causes are only a small component, and our job as non-psychiatric physicians is really to rule out all the rest of the causes before we send someone to psychiatry. So seizures versus CNS infections versus head injuries and bleeds inside their head versus high or low blood sugar versus high CO2 levels in someone with COPD versus liver and kidney issues, high or low thyroid, low levels of thiamine, infections, and then a whole list of different drugs and toxins can result in this as well. So, often these folks are on multiple psychiatric meds, and that doesn't necessarily mean that it's a psychiatric diagnosis that's causing the issues that are presenting to you. This could be something like serotonin syndrome. This could be something like neuroleptic malignant syndrome. And this is why having that temperature as early as possible is key. A few of the history and exam findings that can help direct you one way or the other versus whether or not something is medical versus psychiatric as a primary inciting agent is, with respect to psychiatric diagnoses, usually these initially present in those between the age of puberty and 45. Usually the individual in question has a prior history of psychiatric issues. Often the speech is fast, and they have paranoia and expressions of grandeur rather than simple confusion. Whether medical causes, well, they may occur at any age, are more common in older folks. And often, for medical causes, you'll see someone with abnormal vitals, or you'll find other abnormal findings. So to look a little bit more at the key aspect of hyperthermia, this is something that needs to be addressed as soon as the agitation is controlled, and then you need to work to cool the person as quickly as possible down to 38 degrees Celsius. And one of the most effective way to cool someone who is hyperthermic is with spraying water on them and running a fan. We have a lot of different places got these special cooling devices that can also be useful. The devices that we use for post-cardiac arrest hypothermia, those can be used as well, but they can often be harder to find. If you can just find a fan and you can find, like a plant spray water bottle, that is very effective for cooling someone. When you're giving this initial bolus of intravenous fluids, if you give, cool or room temperature fluids, that will often bring down someone's temperature as well. And one thing one wants to try to avoid is pressors such as, epinephrine or norepinephrine, as these will decrease blood flow to a person's skin and it will decrease the ability for them to cool. Now, of course, there's sometimes places when you can't avoid not using pressors, but if you can, you want to stay away from them, as they'll make treating the person's hypothermia harder. If you need to intubate someone who is agitated, one of the nice things about giving ketamine is it will give you time to prepare someone to be intubated. So you give this large dose of ketamine, and this will give you time generally to pre-oxygenate the person. This will give you the time to set up for intubation. This will give you time to give the person a bolus of fluids. And, while we're typically taught to do rapid sequence intubation, something known as delayed sequence intubation, where you give the ketamine and then 5-10 minutes pass before you give the paralytic, is perfectly reasonable practice in these situations, as one wants to try to resuscitate before one intubates. And then with respect to the paralytic agent, in this case, rocuronium rather than succinylcholine is strongly recommended due to the concern of hyperkalemia from inexcited delirium due to muscle breakdown. With respect to preparing for transport, so one wants to carry out a medical workup and apply physical and chemical restraints as much as possible before sending a person out on a transport. And you always want to consider that whether or not the person needs transport for a medical assessment before one worries about whether or not they need transport for a psychiatric assessment. And with here in Interior Health, we have a life or limb psychiatric transport process and PPO, and one of the keys of that LLTO trigger is that there needs to be an attempt to stabilize the person with sedatives and antipsychotics before turning it over to being an LLTO transfer. Whether you're transferring the patient for psychiatric reasons or whether you're transporting the patient for more of a physical workup, either way, it's important to go through the patient transport network or PTN. One thing we will see from some communities is they will have an agitated individual that they do not feel safe taking care of because they are agitated or they have a history of violence, and one thing to remember is that if it's not safe for the patient to be in your hospital managed, even if you're working in a small hospital, it's not safe for the patient to be in the back of an ambulance at 110 kilometers an hour with just a BLS crew. Our ambulances are not lockable from the inside. And there have been cases of patients who have opened the doors of a moving ambulance to try to make an escape here in British Columbia, and where a paramedic has managed to grab the patient by their scrubs as they're sort of trying to jump out of the door of this moving ambulance. And the only thing the paramedics can do at this point is stop the ambulance as quickly as possible and then just let the patient run away. Of course, the paramedics aren't set up to hold people against their will, whether in hospital, even though it's not ideal in some smaller places, you might not have all the staff needed. It's safer than them being in the back of a moving ambulance with just a BLS crew. So these folks often do need a critical care crew or a nurse escort, someone who can keep giving them medicines during these transport times. So here in Interior Health, we're lucky to have these HEART teams. This is an RN and an RT that go out and from regional centers to the smaller local centers to pick up patients and bring them back to the regional centers. They have the ability to provide full ICU care, and they have the ability to move all levels of agitated patients for all sorts of reasons. If an individual is not formed, for air transport, the standard practice is to have all mental health patients, all agitated patients in restraints. So if the patient's not bad enough to need to be formed under the Mental Health Act, you often consent is needed. Well, consent is needed to apply restraints to make that transfer safe for everybody involved. The PTN physician, the accepting psychiatrist will often provide additional sedation orders that are generally started 60 minutes before transport. For those who are mildly to moderately agitated and being moved for a mental health reason, providing nicotine replacement can also facilitate these transfers, as the option to stop and smoke is generally less during these transfers, especially if the person is going by air. And ideally, we want to move these patients during daylight hours. Yes, it can be difficult having someone, in one's department, unless, of course, you're moving them for an emergent assessment for an underlying physical condition. But if one's moving the patient for mental health reasons, ideally you want to move them during daylight hours when everybody's thinking straight, and there's less risks of things going wrong. But of course, we will move them at all times of the day or night. So a few key points. Is a seclusion room required to manage an agitated patient? The answer is definitely not. A patient needs to be medically cleared before they go in a seclusion room. Agitated delirium is definitely not medically clear. So to finish up, returning to case number 1, 32-year-old male brought in by RCMP, was found running around outside with no clothes on. Paramedics report unable to assess. Patient is aggressively struggling with a police officer on each limb and is covered in sweat. So questions. What level of agitation is this?
The third one, I forget what it's called. High?
Severe.
Severe, exactly. And what is our first priority?
Our and staff safety.
Exactly. So our safety, staff safety, and the patient safety. So all three of those are key priorities. So what would you do next?
Call code white and then restrain the patient and give them 350 milligrams of ketamine.
Perfect. Exactly. So after a dose of ketamine, you find that the patient's heart rate is 140, their temperature is 39.4, and their blood pressure is 90/60. What next?
I think we can initiate cooling, maybe give some IV fluids and do a workup for some kind of infection, and having other things on our mind. I mean, he's not stable for any kind of transport.
Exactly. So yeah, so giving this patient, a liter of cold normal saline, spraying this patient down with water and fanning them, working the patient up for sepsis, for hyperthyroidism, for electrolyte abnormalities, for low blood sugar. And then, putting ice packs in their axilla, putting ice packs in their groin. Who should you send this patient to, and how should you send them? So if you're working in a small community, let's say you're working in a 5 to 10 bed hospital, you're the only doc on. You have 2 nurses. So this is someone who's going to need to go to an intensive care unit, and this is someone you should reach out to PTN to arrange transport for. Perfect. Second case, 45-year-old male brought in by EMS at 3 in the morning, was out drinking all night. When approached, just says, just leave me the blank alone, and mumbles, people are out to get me. Otherwise, the gentleman fairly rapidly stabilizes. What level of agitation is this?
Looks like a mild one.
Exactly. Priorities?
Still the same, just our safety and the patient's safety.
Yeah. And how about next steps?
So we can still do a physical exam and medically clear him, and maybe let him, if there's a really strong history of alcohol intoxication and nothing else is going on, we can just leave him to sober up and to get to sleep and to maybe assess his vitals every couple of hours.
Yeah. So and standard stuff, still important to check the blood sugar. People with alcohol misuse disorder will often develop liver cirrhosis. liver is what stores much of your glycogen. When your liver fails, you go hypoglycemic easily. So, these folks, can often become hypoglycemic, and, it's tough to, the person's definitely not at their baseline. So making sure that they're not hypoglycemic is still important at this point in time. Other things you worry about would be, Wernicke's Korsakov's. So acute on chronic thiamine deficiency. So replacing a person's vitamins, giving them thiamine would be another important aspect in this. And then, potentially giving the individual some haloperidol, some lorazepam, plus or minus, if they settle well, you might be able to avoid doing that. And then, as you said, exactly, keep a close eye on them. Do the rest of your exam, make sure there's no signs of trauma, and rule out, any secondary cause. And then maybe, you might in the end conclude that this is, mostly substance related. Perfect. Do folks have questions?
Could you just maybe please go back to the slide with the doses of medication for agitation so that I can make a screenshot?
Yeah, sure. This one, that one right there?
That will work.
So yeah, 1 to 2 milligrams of lorazepam is what I commonly use for sublingual for mildly agitated folks. 1 milligram for the smaller or the older, 2 milligrams for the large younger folks. You can also use oral haloperidol as well, often at doses of 2.5 to 5 milligrams of haloperidol will also be an appropriate alternative. Great. Any other questions? I'm happy to share the slides with you here as well. I can drop a link to the slides into the chat. Slides are sitting on Google Docs, and they should be freely openable by anyone.